It is my utmost pleasure to introduce the next speaker, Mac DePan. DePan is a name that's nothing new to upstate area, so I'm going to try to do my best in introducing Mac. Mac and I first got a chance to communicate together about 9 years ago about a patient that had 3 ruptures in the aorta from thoracic to the abdominal on various occasions, and that was my first introduction to Mac. At the time, he worked at Ellis. Since over the last 2 years, he's certainly come back to join the Albany Medical Center cardiothoracic surgeons. Mac finished his training at Albany Medical Center. His father did all sorts of surgical work in the upstate area for decades until 1991. Mac went on to NYU to do his cardiothoracic surgery training. He stayed there for a few years, where he ended up becoming the chief of the Veterans Hospital at Manhattan. Subsequently, in 1989, I think Upstate was very fortunate to have the ability to recruit Mac back. Maybe that was always the plan, I'm not sure. But since he truly has developed an incredible reputation in the legacy of his father to provide incredible cardiothoracic care to his patients, his accolades go on and on. All of us know where Mac comes from, his heritage, and the type of care he provides, and his expertise as just an incredible thoracic surgeon and cardiothoracic surgeon. Mac's going to talk to us about cardiac emergencies. Mac?
Thank you, man. I really appreciate the opportunity provided by the Albany Vascular Roundtable to have me speak. It's my pleasure. I was given the topic of cardiac emergencies, and that's sort of a broad topic, so I've chosen to break this up into 4 distinct parts to try to maintain my time. Break it up into sudden death, acute myocardial infarction, cardiogenic shock, and aortic dissections. As a cardiac surgeon, I'm probably really only qualified to talk about 2 of these, but I think it's important to talk about the first 2 to set the tone. Some facts. About 1.5 million Americans have a heart attack every year. 2/3 of these will survive. So out of the 300 or the 500 that don't survive, most of these people are dead within an hour of the onset of their heart attack. Most die before reaching the hospital, and in fact, about 3/4 of sudden deaths occur in the home. A person suffering a cardiac arrest out of the hospital has now about a 20 to 30% survival if CPR is administered promptly. If no CPR, there's only about a 5% survival. The important thing in regards to restoration of respiratory and cardiac function, if that's not done properly and promptly within 3 to 4 minutes, you can result in significant neurological injury. And this is just a quote from Shakespeare talking about time and the waste of time and what can happen. Now, the most common arrhythmia associated with sudden death, of course, is ventricular fibrillation or ventricular tachycardia. Studies have shown that successful defibrillation decreases every minute that you're not defibrillated. Now, AEDs are now available. Studies have shown that the availability of these devices and being placed in public arenas has tremendously helped in the survival of patients. In fact, a recent study that looked at AEDs in casinos and also in airplanes has shown that the survival with sudden death is now up to 50%. This is just an algorithm of the basic life support algorithm showing how to administer CPR. The important fact about this is there's been a recent sort of change in how CPR is delivered and the recommendations by the American Heart Association. That really sort of has to do with more compressions of the chest versus respirations. And as you can see down in the far corner, that the CPR ratio should be about 15 compressions to every 2 respirations. Now, as I mentioned, the most important manifestation of the post-arrest syndrome is a neurological injury. About 80% of patients sustaining sudden death are comatose for at least an hour or more. Fewer than half of the patients that are admitted with a sudden death with comatose result have any neurological or good recovery. And this has now led to a new treatment which has become available, and this is systemic hypothermia. 2 seminal studies were in the New England Journal of Medicine in 2002, pointed out that they had a significant improvement in overall survival and neurological recovery in patients that were systemically cooled down to 32 to 33 degrees for a period of 12 to 24 hours. If I can go back, there's two sort of methods that can be used immediately, can also even be started in the rescue squads, ambulances, with topical cooling and placement of cooling pads, which you see placed onto the patient. Or there is also a device that can be placed directly into the femoral vein and into the inferior vena cava, and cold saline solution can be instilled to systemically cool these patients rapidly to 32 degrees. It is now, and this is a report of the guidelines from the AHA, recommendations that in sudden cardiac death with rest and comatose patients, that temperatures should be lowered to 32 degrees for this time. The results are dramatic. The recent sort of outcomes here at the medical center was told by Ed Philbin is at about a 55% survival with normal neurological function in these patients. Now, acute myocardial infarction. I think everyone knows that the obstruction and the loss of blood flow to the heart, time is myocardial function. So the early administration of reperfusion therapy improves survival. The old historic survivals with acute myocardial infarction that was treated expectantly had a mortality of 30 days of about 15%. With the institution of thrombolytics, we were able to decrease that mortality rate down to about 9%. We now have newer technology with the interventional cardiologist and placement of catheters and balloons, the PCI, within 90 minutes, and has a dramatic improvement in survival where the mortality rate has been dropped down to below 7%. This is just a cartoon to sort of show what we're talking about with an ST segment elevation myocardial infarction. You can see initially there's the plaque that's in the lumen of the artery. Then you have an acute thrombus that develops, and you can see what the EKG looks like, what we're talking about with an ST segment elevation. The catheter is then placed through the thrombus and across the lesion, and then dilated with the stent and restoration of blood flow. The other slide shows the survival improves with the shortening of time, and the standard now has been 90 minutes with door-to-balloon times to reestablish flow and dramatically decrease injury. There have been problems to sort of develop this. Understanding right now there's only 3 centers in this community that do acute interventions. A lot of patients live elsewhere outside of the area and time getting to this. But even in the local area, trying to get these patients through the emergency room up into the cath lab had been a quite daunting task. And over the last 5 to 6 years, with team efforts, involving the emergency departments, the catheterization labs, the cardiologists, and other interventionalists, they've been able to have great success. And I think most all of the primary intervention sites, Ellis, Albany Med, and St. Peter's, have door-to-balloon times below 90 minutes that far exceed the national average. Now, one of the complications of an acute myocardial infarction is shock. And the incidence occurs in about 5 to 8% of patients with a STEMI infarction. The vascular system is markedly involved, as well as neurohumoral and cytokine systems, both in the pathophysiology of the shock state and also of the persistent state. We know that very rapid revascularization saves lives. It saves myocardial cells, it saves myocardial function. And there are newer mechanical devices that are now become available, which we can actually support the heart as it recovers from the reperfusion injury. The slide on the right-hand side is just a cartoon of the pathophysiology of the shock state. Basically, with the myocardial infarction and injury, the loss of the myocardial pump function results in a low cardiac output. That results in hypoperfusion to the end organs. The body's response to this is to increase catecholamine response and release. This again sort of whips the heart, increases the myocardial demand, which cannot now be met by the infarcted or occluded vessels, and it's just a cat sort of chasing its tails with a gradual deterioration and drop in perfusion. These patients present and come in, they're anxious, they're cold, they're pale, they're hypotensive, they have oliguria, and also often altered mental status. It requires prompt intervention and diagnosis. One of the important interventions is a very quick assessment, echocardiogram, to take a look at the heart to assess the function, but also to rule out other complicating factors that may be either contributing or actually causing the shock. Myocardial infarctions can be complicated by things such as a ventricular septal rupture from an infarcted septum between the right and the left ventricle, free wall rupture with contained hematoma into the pericardium or acute tamponade, or actual rupture of the papillary muscle, particularly the posterior papillary muscle, which is the support of the mitral valve, resulting in severe mitral insufficiency and low cardiac output. Also, aortic dissections can present as cardiogenic shock from either rupture into the pericardium with a tamponade or acute occlusion of the coronary arteries with a massive infarction. Treatment options, as mentioned here, is very acute revascularization. Patients are supported very rapidly with insertion of an intra-aortic balloon and taken directly to the catheterization lab for diagnosis and then interventions, more often PCI. But in the shock trial that was done, about 30% of those patients received acute bypass surgery. I'd say probably in the community now, the incidence of acute bypass surgery for cardiogenic shock probably is about 10%. But in states of severe triple vessel disease or left main disease, as here in this algorithm by the American Heart Association, it is recommended that cardiac surgery and coronary bypass is superior to PCI. Some of the newer technologies that we have with beating heart surgery have improved the outcomes with bypass, where in the past years where we had cardiac plegia and arrest of the heart, we had poorer outcomes. This is the cartoon of an intra-aortic balloon. This is a device that is rapidly inserted percutaneously through the femoral artery and up into the descending thoracic aorta. The balloon inflates and deflates with the timing of the heart. It's set to immediately inflate right after systole and during the diastolic part of contraction. And what that does is it increases perfusion back to the heart by pushing the blood in the ascending aorta back towards the coronary arteries. It also pushes the blood distally in the distal aorta and improves the peripheral circulation. At the end of diastole and just prior to systole, the balloon then immediately deflates, and what this does is lower the afterload of the heart, so the left ventricle is now not seeing quite a large afterload resistance when it does contract. This helps to support the circulation until the patient can be appropriately revascularized. Now, the shock trial was impressive to sort of show that with early revascularization we had significant improvements. The old historic sort of data that patients with acute STEMI infarctions and developing a cardiogenic shock, their survival was very poor, usually only about 25%. But with the rapid institution of revascularization, we're now showing that survival is upwards of 50% in these patients. And this slide shows that the difference between early revascularization and also versus just routine medical stabilization. The other important thing is that the patients that survive this and get through their shock state, they actually do well long term. Okay, they do have a very good prognosis. And the following slide shows that there's a dramatic improvement in their quality of life, at least in the first year after their event, if they're treated with early reperfusion. Now, sometimes these patients just don't make it just with an intra-aortic balloon or revascularization. And so now we have available to us a whole host of new devices in which to support the failing left heart. Some of these are percutaneous or easily inserted devices. Others require a trip to the operating room for placement. One of the newer devices that's available is called the Impella device. What this is a catheter device. It is a centrifugal pump, a small circular pump. This is inserted percutaneously or through a femoral cut down into the femoral artery, up through the aorta, across the aortic valve, and into the left ventricle. When turned on, this can provide circulation of 2 to 4 liters of outflow. What it does is suck the blood out of the left ventricle and then distribute it down into the descending thoracic aorta. The other device that now has become available is called the tandem heart. What this is again, is an left ventricular assist device. This can be placed either percutaneously or again also through a femoral cut down. It doesn't have to be placed in the operating room. It can be done in the catheterization lab or in the critical care area. One catheter is placed through the femoral vein, goes up into the right atrium, then passes transeptally across into the left atrium. From there, it draws the blood out of the left atrium through the pump and back into the femoral artery. We can obtain flows of 5 to 6 liters with this device and support the failing left ventricle. It is a temporary device and can be used to acutely stabilize patients or also to support patients during complicated revascularization procedures. The third device is the HeartMate device. And I chose this as just an example of a more permanent or surgically placed left support heart device. It's placed surgically. It involves making an incision into the apex of the left ventricle and insertion of the device into the left ventricular cavity. The centrifugal pump that you see here then throws the blood back through the graft into the ascending aorta. This is the standard device now that it's being used in most centers for not only acute left ventricular heart support, but also long-term heart support. It's the device that Dick Cheney has. It does require sternotomy or thoracotomy for placement, but it can be used on a short-term or a long-term basis until either the patient can either be bridged to transplantation or can be weaned from the device. The last device is the ECMO, or extracorporeal life support system. This again is a percutaneously inserted system. The difference between this system is it not only supports the circulation, but it also supports the respiration. So there's an oxygenator that's also into this system. Catheters are placed percutaneously into the femoral vessels, and with this you can place the patient on complete bypass, supporting their respirations and keeping them well oxygenated as well as perfused until the heart recovers or until you can place a more permanent device or find a heart for transplantation. Now, results with these devices have been pretty dramatic. A study back in 2006 from the University of Pennsylvania looked at about 50 patients that had acute cardiogenic shock and then went on to have immediate placement of these left ventricular assist devices, the type where you opened up the chest, put them in through the left ventricular apex. They had a 74% survival with these devices. They were able to wean these patients and support them till they could be successfully transplanted. And of those patients that were transplanted, 87% of those survived to leave the hospital. This most recent study in 2010 from the University of Pittsburgh looked at the ECMO device's support during acute resuscitation for cardiogenic shock. And as you can see, 26% of the patients were able to be weaned from the device and actually left the hospital alive more than 30 days. And the interesting point, again, is that these patients can do well. All right, they can have a good quality of life. And the following slide shows that the 5 years, or the 50% survival goes out to almost 10 years. So the fact that you have shock doesn't mean that things are all over. And that with these newer devices that we have, the rapid revascularization, these mechanical devices to support the failing heart until it recovers. As long as we can keep the circulation going and keep, without any neurological injury, we can have some significant salvages of these patients. The last topic, and the thing that keeps the cardiac surgeon up at night, is aortic dissections. This diagram shows what an aortic dissection is. Basically, a tear occurs in the intima of the aorta, and the blood travels out of the true lumen into the media, creating a false channel. The picture there is an intraoperative picture of what a dissected aorta looks like. A big blue hamburger. These are devastating complications, okay? It was interesting when I looked at the data to find that these are actually more common than ruptured abdominal aneurysms. The incidence occurs in about 1 to 3 of every 100,000 people in the community. The usual sort of causes is most often these patients have developed an intramural hematoma within the wall, which then ruptures. Also association is significant atherosclerosis with penetrating ulcers, or conditions where there's an abnormal media of the aorta, such as in patients with Marfan's or other patients with cystic medial necrosis. Associated factors that are involved with dissections are things such as hypertension, increased cardiac output states, bicuspid aortic valvular disease, patients with congenital abnormalities of their aorta such as coarctation, or also, manipulation of the aorta from angiography, catheterization, cardiac surgery with cannulation, cross-clamping, and other types of manipulations of the aorta. When we look at dissections, we classify them. We have two types of classifications. There's the old DePan classification, Michael DeBakey's first description of this, and the Stanford classification. The DePan classification is based upon two things. Number one, where is the intimal tear, and how extensive is the false lumen? The Stanford classification is more functional, and it really says, okay, where's the dissection? Is it in the ascending aorta, or is it in the descending aorta? And that has a significant play as to who gets called. If it's in the ascending aorta, the cardiac surgeon gets called. If it's in the descending thoracic aorta, the vascular surgeon gets called. If there's occlusion of the mesenteric vessels, patient can present with acute abdominal catastrophe, significant acidosis. Occlusion of the renals results in anuria. Occlusion of a iliac or femoral vessel will result in significant limb ischemia. The other thing is that false lumen may not only just expand, but it may rupture. And depending upon where it ruptures, if it ruptures into the mediastinum, that just results in significant loss of blood. If it ruptures into the pleural space, patient's dead. If it ruptures into the pericardium, patient may be dead or will soon be dead if he doesn't get prompt surgical care. These are pictures, x-rays. The first x-ray showing the chest x-ray where you see the widening of the mediastinum related to the extravasation of blood within the mediastinum as well as a right pleural effusion. The diagnostic technology that we utilize now for acute dissections is the contrast CAT scan, and the sine qua non is to see the two lumens of the aorta, which are the true and the false lumens. Most often the false channel is larger than the true lumen. There are several things that we as cardiac surgeons are asking when we see or get called to see a patient with an aortic dissection that we sort of need to know. Number one, we want to know whether it's in the ascending or it's in the descending. We'd like to know where the tear is. We'd like to know if there's any associated branch occlusion. Is there any evidence of a pericardial effusion? Is there any evidence of aortic insufficiency? Because this disruption can disrupt the aortic valve. It's in continuity with the aorta and result in significant aortic insufficiency and shock for the patient. Surgical treatments for this. The primary points in the surgical treatment of aortic dissections is one is to prevent further extension of the dissection. Second is to eliminate the tear from the circulation. And the third is to remove the aorta that is most prone to rupture, and that being the ascending aorta, because there's nothing around the ascending aorta. It sits into the pericardium, as opposed to the arch or the descending thoracic aorta that has mediastinal tissues which may help to sort of tamponade any significant leak or rupture. Recent surgical changes and alterations with better grafts, better suture material, hemostatic agents, as well as better perfusion technology have really dramatically altered our approach to these aneurysms. It used to be an absolute disaster when you had to be faced with dealing with an acute aortic dissection, and now it's become pretty much almost somewhat routine. Several months ago, I think I had a period where I had one every week for 10 weeks. Our approach is peripheral cannulation. We usually utilize cannulating the axillary artery as our access to perfuse. This allows us also to promptly cool the head and put the patient under deep hypothermic circulatory arrest, and which then allows us the time and the clear operative field to be able to reconstruct the arch or to sew these fragile tissues together without a clamp onto the aorta. This is an example of resection of the ascending aorta with also repair of the undersurface of the arch, what we would call a hemi-arch replacement. The newer grafts are very permeable or impermeable to blood. They are also very soft and take the suture material very well. You note that there's this sort of soft, or what I would call pledget sort of material onto the outside. This is necessary because this tissue is almost like wet toilet paper when you try to sew it together. More extensive dissections that involve the arch require complete arch replacement, and this involves complicated different types of bypass things. The most common sort of approach now is our newer trifurcated graft, where we have direct anastomosis to each of the arch vessels, which is then reattached to a aortic graft going from the ascending aorta down into the descending thoracic aorta. The mortalities have dramatically improved. The stated now mortalities for acute aortic dissection involving the ascending aorta is less than 20%. In arch dissections and arch replacements, it's about 25%. And with the newer technologies, particularly with endografting and also stenting and fenestrations for the descending thoracic aneurysms, the early mortality is 10%. The historical mortality for surgical repair of dissection of the descending thoracic aorta was well above 35 to 40% in the past. Late survival is very good with these patients, particularly if they're followed closely and their blood pressure is controlled. Survival is about 85% at 5 years and 65% at 10 years. About a third of the late deaths are results of persistent problems with that false channel. If the blood pressure is not controlled, you will have problems with that false channel. It will enlarge and you'll have aneurysms which you'll have to deal with. Redissections occur in about 10% of the cases and are obviously much higher in those patients with cystic medial necrosis or Marfan's. So I'd like to thank you for your attention and appreciate the opportunity to speak to you.